Hello and welcome again to another edition of the Osteopathic Lyceum podcast. I'm going to go through a paper from the Journal of Osteopathic Medicine. This was published July 28th of 2023. The title of it is Ultrasound-Assisted Bony Landmark Palpation in Untrained Palpators. Something that I've actually gotten ads for on varying online platforms is point-of-care ultrasound, and there's one that is... It's got different levels and different heads and whatnot, and it's got an AI assist. I don't remember the name of the company, but they're targeting people that they have any reason to believe may be in healthcare. One of the problems with something of that nature, depending on the jurisdiction that you're in, is that you may not be allowed to do anything interpretive with it. So you might be able to have it, and maybe you feel like the AI tool is going to help you identify things in the way that you want to, but you're not actually allowed to use it just because of the legal framework under which you work, right? So it might sound sexy, but be very careful with it based on your jurisdiction. You kind of got to know the laws. With respect to Canada, I would have no legal right to be able to utilize that for any form of imaging interpretation, regardless of what the AI assistant would be able to do, on account of the fact that I would be breaking the RHPA, or the Registered Health Professionals Act in Ontario. Whereas the context in which this paper was generated in America, students of osteopathy who are going to become doctors of osteopathy will have unlimited medical licenses and would be allowed to utilize image methodologies appropriately in their legal framework. So to get into this, the introduction actually has some interesting information, so we'll read through the introduction and then get through the rest of the paper as I am wont to do, or as I like to do. Anyways, to read, the use of handheld ultrasound devices in medical education is an emerging modality for improving the effectiveness of palpation and physical examination training. Although palpatory skills remain to be one of the key pillars of the bedside physical examination, fourth-year medical students have poor palpatory skills. A study by Stansfield et al. Showed that only 4 to 26% of the 45 students enrolled were able to perform the examination perfectly. A common obstacle noted by students is the difficulty in identifying and palpating bony landmarks and musculoskeletal structures in patients with a higher body mass indexes, BMIs. So first, I want to make a simple note that you must assume that the identification of bony landmarks is important in clinical practice. Depending on the form of clinical practice that you're in, it may be more important than in others. With respect to hands-on manual therapy, I would actually argue that it's not that important. It's where it doesn't move that is more important than being able to name the specific thing that you're touching, because you're in a low-resolution environment of observation with respect to structures that are deep to the skin. While some may be more easily identifiable, some of them are actually hard to identify almost regardless of the patient. And also you have to make assumptions that things are as you believe they are underneath the skin to be able to claim that you're touching a specific structure. Again, some are more obvious, right? Clavicle's not that hard to find. Things like the base of the occiput, well, not the base of the occiput, like the superior nuchal line. The inferior nuchal line, very hard to find, but you can assume that you're in the area. Something like the olecranon, something like the greater trochanter, not terrible to find. They're big. They're in places that are not that hard to identify. The sacrum, broadly easy to identify. Specific points, very hard to identify because of sensitivity, but also varying levels of tissue presentation. So you, again, have to assume that accuracy of bony landmark means what you think it means, and I would argue that it probably isn't as important for hands-on manual therapy. For physical examinations that would lead to further request for imaging or further request for exploration and diagnostic, sure, right? So for a gastroenterologist, maybe more important. But the gastroenterologist is going to go image anyways. They're not going to rely on palpatory findings. So you have to buy that it really matters. I would just argue that it doesn't matter as much as most people think it does. It is cultural reproduction more than something that matters clinically, as far as I can tell. I'm happy to be wrong, but based on the length of time that I've been doing this, been teaching this, been trying to learn more about all of it with respect to hands-on manual therapy, I don't find bony landmarks trustworthy. I don't find all of them accessible in the way that one would hope. And I also don't find that they're the most comfortable to be palpated for the patient, because often more bony prominences have tenderness to them, and people can feel different ways about where they're being assessed. So if you're just checking for motion and whether or not things yield to pressure or things squish or don't squish, they don't seem to mind broadly. Most patients don't seem to mind broadly. However, when you poke them in certain spots, they can start to self-reflect and be uncomfortable, at least with respect to my experience. I may be very wrong, but that's what I've experienced so far. And now we need to just touch briefly on BMI. There are a lot of arguments about the usefulness of BMI. BMI is basically mass over surface area. So it's height as an assumption of surface area, and then weight, and then you do division and you get a number. And it's a really, really, really rough, quick method to get a proxy for danger signals or possible predictive signals with respect to certain disease processes. Yes, there is no ability to differentiate between mass that is generated by muscle versus mass that is generated by other forms of tissue. And it doesn't directly predict poor health outcomes, but it is something that will give you a really rough guide as to certain things being more likely. So higher BMIs are going to be more predictive of the onset of something like type 2 diabetes. The argument then would be, well, a bodybuilder is not as likely to have type 2 diabetes as somebody who may have more subcutaneous fat at the same BMI. And sure, fair enough. However, a bodybuilder carrying excess mass is putting a lot of challenge to their circulatory system. So bodybuilders will oftentimes have very similar predictive paths with respect to some of the things that you could begin to consider because of a higher BMI. So higher BMI is hard on a human body regardless of what tissues it is, and it's really rough. To behave as if it's a specific predictor misunderstands its point. It is a rough predictor, very rough, where you still have to interpret based on context and based on other findings. Somebody can have a high BMI and no other signs of any disease process. They can have a low BMI and signs of disease processes that you would assume would be present with having a high BMI. So you still have to really check things. But if you wanted let's just say a rough epidemiological predictor with respect to who's more likely to end up having some form of generalized likelihood of certain disease processes, BMI does the trick, but it doesn't differentiate between individuals and context. So you do still have to do that. So really, when you see BMI in a palpation study, please excuse the roughness that some may interpret here. It's trying to figure out if you're fat, right? Like that's what it's trying to figure out, if you're obese. So you have classifications within BMI. Certain ranges of BMI are considered overweight, some are considered, and then beyond that, it's obese. So what they're doing is they're trying to find a relatively polite scientific way of saying, hey, it's harder to find bony landmarks on people with more subcutaneous fat. And fair enough, right? So there are certain areas on lean people that will have an odd amount of subcutaneous fat that you wouldn't assume is there because they're relatively lean, and people have variable fat distribution, especially subcutaneously. So it'll still trick you. They can have a low BMI and still have an area where there will be more fat than you would expect, which would obscure certain landmarks. So again, you still have to check, but as a really rough guide, a higher BMI does predict that you're going to have a harder time finding bony landmarks. But before you even do that, you have to assume that bony landmarks matter. Anyways, to read again, the average American BMI has risen from 23.1 in the year 1976 to 27.7 in 2018. Medical students with no prior palpatory experience may find it difficult to ascertain specific bony landmarks in patients with a larger habitus due to the presence of excess skin and soft tissue. Again, see how they're trying to be respectful and polite, which I think is completely fair. They said, how did they say it? Blah, 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 blah. Excess skin and soft tissue. The soft tissue is probably more accurate. The skin is probably not the thing because skin is fairly immobile. To read again, multiple attempts have been made to address this difficulty in palpating landmarks in obese patients, including ultrasonography to assist procedures such as lumbar punctures and epidural anesthesia. I would say that that's smart to do anyways because those procedures do have danger. So because of the danger, if you use ultrasound anyways, regardless of BMI, you're probably doing everybody a favor, patients and practitioners included. To read again, in a study population of 10 physical medicine and rehabilitation residents, Setterberg et al. Noted that incoming residents have poor palpation accuracy. The incoming residents palpated and identified 2 bony landmarks with a combined accuracy of only 35%, demonstrating the need for improved musculoskeletal palpation training earlier in their careers. So by the time they're getting into their residency, they're having a hard time finding the bony landmarks. In a study by Walrad et al., 27 first-year medical students were instructed to palpate shoulder and knee landmarks after an instruction period with ultrasound, resulting in significantly higher palpation accuracy in shoulder landmarks versus knee landmarks. The study showed a performance assessment score of 71.6% for ultrasound-guided shoulder landmark palpation versus 56.1% for ultrasound-guided palpation of knee landmarks, with the main difference being between groups being the non-bony landmark of the biceps tendon. What I'll say is that the knee, while large, the smaller subcomponents don't differentiate particularly well. It just kind of feels like a lump, whereas the shoulder, the geometry of the shoulder changes more obviously. Things like the deltoid, things like biceps tendon. The biceps tendon, your confidence that you actually got it shouldn't be that high, but it's in an area and it's big enough that you can sort of figure you got it, especially if you continue to roll over it and it's a little clunky. So you can have reasonable confidence there, but the knee landmarks a little harder because knees are a little bit different than one another and it's just like a big lump. And there is a decent amount of muscle tissue relatively close to it that can obscure stuff as well, not simply other forms of tissue. So whatever. A systematic review, to read again, conducted by Galusco et al. Found many studies have emerged with ultrasound being utilized in emergent settings such as point-of-care ultrasound scans for trauma examinations of soft tissue structures in the emergency department. However, their review highlighted the relative dearth of studies regarding the use of ultrasound in musculoskeletal cases. I would say that one of the really, really important parts of ultrasound in MSK cases is the ability to differentially diagnose the presence or absence of a tear, because that would change how you would approach an area. Without a tear, you approach with caution. With a tear, you don't move it. To read again, other studies have also found that ultrasound integration during medical school was received positively by student physicians who wanted it integrated in the curriculum. Shiny object technology, yay, fun. If there's no performance metric associated with it, you're going to have a hard time getting me as an administrator to utilize something. Maybe others would be easier. I don't know. Anyways, to continue to read, because there is something positive a little bit later on here, I think right in the next sentence. To read again, 4th-year medical students who were taught bedside ultrasound skills during medical school were more likely to be prepared and proficient in the use of ultrasound in appropriate clinical and emergent settings during their residency and in further practice. Who knew? You teach somebody how to use something and they get better at it. Students who were given immediate feedback and instruction while learning and utilizing ultrasound also showed a significant improvement in image acquisition skills. Hey, when somebody screws up, you give them the feedback that they screwed up and they get better because they don't know what the error was, but you tell them what the error was and they get better. Who knew? It's not like it was the exact finding of my thesis experiment. Wow. So maybe you didn't know, but I did. Yeah. Yeah. Anyways, to read again, ultrasound-assisted musculoskeletal palpation training has begun to be integrated in PM&R residences. Studies indicate a significant improvement in 10 PM&R residents from 20% to 51.7% in not only palpation accuracy to those residents who attended ultrasound training sessions, but also in residents' confidence in palpation. So if you've got both, they're more accurate and they have more confidence. I like that better than just they liked it, or they have more confidence. To read again, a subsequent study by Bitterman et al. Outlined a proposed ultrasound curriculum to be a consistent part of PM&R residency program. This curriculum showed significant improvements in resident skills in accurately palpating joint lines, tendons, and bony prominences in the upper limbs. Again, like, I don't know what the point of palpating a bony prominence is, like, other than assumed symmetry, because it doesn't necessarily tell you anything. If you were to check my particular tibial tuberosities, both are large because I have Osgood-Schlatter's. One is much larger than other, and that happened between the age of 30 and 35, and I am pretty sure I'm currently 44. It's one of those deals where you consistently forget your age because you don't think about it that much. Am I 40? Yeah, I'm currently 44. I am currently 44. Anyways, I just don't. Bony landmarks are tricky because they're not necessarily symmetrical, and they are often taught to be assumed as such. And if you see asymmetry, you should do something about it. I just don't know if I buy that. Blah, blah. Yeah. To read again, although there are not many studies on ultrasound integration into the medical school curriculum, 16 chiropractic interns were taught how to identify the medial meniscus, lateral malleolus, and lateral epicondyle of the humerus by ultrasound-aided palpation, noting a statistically significant improvement in the accuracy of palpatory and identification skills on the medial meniscus and lateral malleolus. Does that say lateral malleolus? I'm hoping that's of the tibia or of the tibia or the femur. Yeah, I really hope that, because it's like if you can't find the lateral malleolus of the ankle, got a bit of a problem. After a 3-minute ultrasound tutorial. In a study involving 64 first-year osteopathic medical students displayed more confidence and accuracy in palpating specifically the bicipital tendon of the shoulder after being taught to utilize ultrasonography compared to the control group. That's fine. I'm fine with that. To read again, the study was conducted at an osteopathic medical school and included palpation of both bony and tendinous landmarks of the shoulder. The study, however, also noted that although there was greater accuracy in identifying the bicipital tendon, the small improvement in accurately palpating bony landmarks of the shoulder in the ultrasound group was not statistically significant. What that could say is that finding the bony landmarks is just not that hard with respect to the shoulder, at least the ones that are not covered by a bunch of meat. Because there's a few, right? So you can get to the AC joint, you can get to kind of around the acromion, scapular spine, head of the humerus, no. Don't try to find that. But yeah, biceps tendon, not terrible to find. Excuse me. To read again, so one of the reasons I'm reading this is just so that there's some background as to why this group did this experiment, because the introduction is supposed to build the case for why you're doing something. And I think they're doing a decent job. To read again, with the wide availability of handheld ultrasound probes such as the Butterfly IQ, many physicians are seeking training in utilizing ultrasonography to accentuate and assist in the clinical and procedural skills. We aim to introduce ultrasound as a learning modality in medical school education before entering residency in the interest of teaching greater accuracy in palpating bony landmarks. In this study, we seek to identify whether utilizing ultrasound assistance in teaching palpation of specific thoracic vertebral bony landmarks will improve palpation accuracy in first-year medical students with no previous palpatory experience. Excuse me for a moment. So yeah, they've set up why. They're trying to see if they can get you early, which I think is valuable. The earlier you introduce a skill, the longer somebody has to learn it, make mistakes, refine, improve. So at the time that they have to use it, they just have more experience. They're more of an expert at initial application in an important way, or initial application in a clinical setting where they're kind of on their own. So that does matter. So methods. Kansas City University Institutional Review Board approved the research study, which was supported by an intramural grant funded by Kansas City University. So the reason that you note those things is so that you're noting funding source, so people can make skeptical hippo eyes. They can try to figure out if they trust you due to your funding source. Also, if you didn't get the IRB, you wouldn't be able to publish. So you have to prove that you attempted to go through IRB and that IRB either exempted you or provided you proper, they granted ethics approval is probably the best way to say it. Otherwise, you're just not going to be able to publish. To read again, a total of 166 first-year medical students were recruited and given the opportunity to participate in the study during their orientation weeks via email and flyer announcement and through open enrollment. 32 students volunteered and consented to participate. The study participants were all first-year osteopathic medical students in their first week of orientation before the start of any osteopathic palpatory training. Demographic information such as age, sex, and previous profession was not collected. The data were collected in a single session at the end of the first-year medical students' orientation weeks. The study was performed in the Osteopathic Manipulation Laboratory at the Kansas City University Joplin campus, with the study area hidden behind a wall partition. Part of that was probably just to maintain some dignity. Right? But in medical school, a lot of your dignity gets lost depending on where you go. Anyways, to read again, in the first station, the subjects were brought into a partitioned area with a manipulation table, skeletal spine, and a laptop with an instructional video. Study participants were asked to watch an instructional video showing relevant anatomy and locations of the bony landmarks relevant to the study, as well as demonstration of palpation and location marking with an invisible ink marker. The reason that you want to describe that is because you want to show what you did that was the same for all participants. So if somebody wanted to try to repeat this, they could. And also, if they all got the same thing, then you can say it's not the teaching, it's the individual. So the variance is the individual as opposed to the teaching, because the teaching is the same. To read again, the participant was then asked to practice on a spinal skeleton on their table. After watching the video, the participants were then instructed to palpate the prone human subject and mark a single dot, not circle, on any transverse process located between the shoulder blades. No time restriction or limit was given to the participant for any part of the study, so the participants went through the video and study at their own pace. A proctor was available to hand an uncapped invisible marker to the patient, and the proctor was advised to give no instruction to the participants other than to redirect the subject if they were palpating outside of the control area T2 to T9. There was no confirmation or adjustments made by the proctors to redirect the participants if they were not on a transverse process. After marking, the subject then returned to Station 1 and played the instructional video, which demonstrated ultrasound probe usage, basic technique, and identification of landmarks with the ultrasound. So I'm going to pause really quickly. T2 to T9, or anything in between the shoulder blades, just is obscure because there's so much tissue. So the shoulder blades, depending on where the arms are positioned, can crowd the area. The muscular tissue, you have muscular tissues which can be quite well developed depending on the person, in the form of the trapezius, in the form of the rhomboids, major and minor, if they have minor, which you don't know unless you have some imaging technology that would show you that, or you cut them open. The other deal is that you have ribs, and ribs will be confusing because if you feel something firm, depending on where you are, how close to the SP you are, it might be tough to figure out what you think you're on. So the ability to differentiate between rib and transverse process beneath all that tissue, very, very tough. So it's a tough area to discern because of all of the things happening there. Also, in between the shoulder blades is an area where people will carry a decent amount of subcutaneous fat, depending on who they are and their current state of leanness. And even some people who are generally lean may have a decent amount of subcutaneous fat there. So it's a confusing area. Excuse me. I don't know why you want to feel a TVP there anyways. I don't know. Especially because the SPs don't necessarily line up with TVPs properly, so you get the rule of threes stuff that people just talk way too much about in manual therapy, at least at the educational level, in my experience. I just don't know why you'd want to touch it. But, if you're trying to figure out if the ultrasound is going to help you find something accurately in a confusing area, that's a great area to do it. To go back here to read, the subject was then asked to return to Station 2, where the proctor had a butterfly IQ probe ready with gel hooked to an iPad set on MSK mode with a depth of 67 centimeters. The research assistant handed the subject the probe and allowed the subject to locate their landmark, and then the research assistant was ready with an uncapped invisible marker of a different color to allow the subject to make their second mark. The proctor was instructed to not give any feedback, tips, or communication other than instructing the subject where to go and redirect the subject to the control zone for palpation if needed. So yeah, just like if they're out of bounds. One of the things about somebody who could provide feedback is that if the feedback is uneven in any way, then that could be the reason why some people perform better as opposed to others. So you can't have them providing any feedback. To read again, after the subject left the area, the proctor visualized the invisible ink markers. Using an ultraviolet flashlight, the control markings for the transverse process were done prior to the study by a board-certified clinician with experience in ultrasound diagnostics and procedures. Control markings were done with an invisible marker in the color blue. The color blue was utilized because it was found to be resistant to wiping off with alcohol. The clinician marked the most posterior superficial aspect of the transverse process of T2 to T9 bilaterally on each human palpatory volunteer. The proctor measured the participants' palpatory and ultrasound marks against the control markings utilizing a digital caliper and documented the distance in millimeters on the participants' data sheet. So just something really simply, if you're doing something like this, you have to trust that the expert did it right, and they probably did, but there's room for error. One of the arguments in the favor of things like mannequins or models, like models that are not humans, is that you can know for sure where things are and adjust them to know for sure. One of the problems with that is that students learning on mannequins or models learn on mannequins or models, not humans. So they don't gather the experience from interacting with, a living human being, because learning does tend to be broadly modality specific. So you can get better at palpating the mannequin, but maybe not better at palpating the person. So there's challenges there. It doesn't mean anything's wrong with this. It just means that you'd want to make a mental note of that and say, well, maybe they didn't do it right. But you're looking at the difference between them. So you're comparing expert to novice. Anyways, to continue to read again. After documenting the data, the proctor cleaned and prepped the prone human subjects back for the next participant. To analyze the data, the authors utilized IBM SPSS version 23 to calculate repeated measures, analysis of variance, ANOVA on palpation, and ultrasound accuracy and landmark location, first utilizing all students, then segmenting students based on patient BMI, utilizing 3 levels for this independent variable: normal, overweight, and obese. To read the results quickly here. No, maybe not quickly. Who knows? Whatever. You're still here, I guess. A test of the overall hypothesis that participants will show improved accuracy utilizing ultrasound compared to with hand palpation was not significant when separating students. So it didn't help much in the area. It's a confusing area. It's actually hard to do a good job in that area for accurate palpation of anything other than SPs. To read again, when separating students into groups according to patient BMI, however, there was a trend towards significance for an interaction effect between patient BMI and repeated measures variable of palpation / ultrasound. When looking specifically at only those participants working with a normal BMI patient, there was a significant improvement in their accuracy with the use of ultrasound. And part of that's going to be because the actual structure is going to be more apparent upon palpation. You can find it properly often with the ultrasound, but to then be able to actually touch it because of the amount of tissue between where you are and where that bony structure is being larger, it's just harder to do. Also, this is consistent with what I'm aware of in almost any other area with attempting to find bony landmarks in the vertebral column. Higher BMI makes it harder to be accurate. That's a pretty standard finding for bony landmarks. Right, so the results section is pretty quick. To read the discussion, the purpose of the study is to demonstrate if ultrasound may aid novice palpators in their accuracy with regard to palpation of bony landmarks. Palpation of bony landmarks is a foundational skill in osteopathic medical schools. It is a foundational skill, but I'm not sure it has to be. For physicians, for DOs, I'm more in favor of it. For the rest of us that are just doing hands-on manual therapy, I actually am not as in favor of bony landmarks, because we don't treat bony landmarks. We treat how things move. We find how it's moving, and sometimes we relate it to the bony landmark, and we go, look, the ASIS has moved. I'm like, I doubt it. But the test that you did may show a change from how you did it the first time to how you did it the second time. If you did it the exact same, then it shows change from pre to post, but it doesn't mean the ASIS is really that different. Sometimes you just wiggle them around on the table, and now they're laying more level. To read again, learning palpation of the thoracic transverse process is a task that many students initially find difficult. Yeah, because it's difficult. The author sought with this pilot study to quantify the potential benefits of adding ultrasound to the initial learning of transverse process palpation. Improved accuracy in palpatory skills can directly affect patient outcomes with respect to diagnostic and procedural accuracy. Yeah, if it needs the bony landmark, yes, fair enough. For a DO, I think that's way more important. To read again, the results found improved accuracy with ultrasound-guided landmark evaluation than palpation alone in a normal BMI volunteer. BMI of 18.5 to 24.99, but not significantly improved when palpating overweight BMI 25 to 29.99 or obese BMI 30 plus models. Palpation and imaging of subjects with higher BMIs can be more difficult due to the increased quantity of tissue, like I already said. In a similar study, identification of the L3 spinous process on a patient model with a BMI of 19.4 yielded significantly more accurate results with ultrasound assisted palpation. As again, I already said, BMI impacts the identification of bony landmark anywhere. More studies are needed to identify whether there is greater improvement in the accuracy of palpation skills with the increased presence of ultrasound-assisted palpation training. We hope to see the study repeated with a larger population to simulate the larger scale needed to teach ultrasound in medical schools. One of the things that I'll say is that if we see a signal that there is a benefit to patient outcome with respect to the increased accuracy here, say for DOs, for specific procedures, use it. I don't know that you're going to see anything for hands-on manual osteopathic practitioners or massage therapists or even physios with the use of ultrasound. Ultrasound is probably going to be useful for those who are allowed to use it to identify presence or absence of tear and be very, very valuable, because if there is a tear, you don't move it. Therefore, you're less likely to injure the person because of the manual treatment. If there is no tear, then you can say, I'll proceed with caution based on what I find. So for that, sure, but for the accuracy, I just don't know that it matters, because I'm as accurate as I need to be when I find where something doesn't move. So if I find a region in which one side moves freely and the opposite side doesn't move particularly freely, I'm accurate to the test. It doesn't matter what level I'm on. It matters that I found where it doesn't move and I restore movement to it, because that is accurate. But to name it and number it, kind of doesn't matter. Maybe to some people it does, but I don't think so. So I don't think a lot's going to come out of this for manual therapy per se. And also, I would want to see a bigger impact on things, even in the pilot study. They see some signal, but whatever. Do I want to read that? Yeah. Really quick. I just want to check something real quick. Yeah. So the basic conclusion is, is again what was already said. We found improvement in people with what would be considered a normal BMI as far as accuracy with ultrasound and palpation versus those with higher BMI in either the overweight or obese category. You can argue with those categories. I'm all for it. I get it. But it's a really rough category to probably be a little bit more respectful in how you describe somebody's amount of tissue in a given area or body wide. It's a normal phenomenon that it makes a difference. Ultrasound doesn't seem to help. If it doesn't seem to help as much with respect, at least to novices. Now, those people who are more experienced, you might see more signal. They might maintain accuracy regardless of BMI, and you could look for that. That might already be there. They did note that higher BMI in another study did impact it. It was the one who was a fairly low BMI, was like 19.4, accuracy was better for identifying L3 on them, I guess, than people with higher BMIs. So that is some signal. What I would say is that regardless of ultrasound, probably the signal you're going to see, regardless of expertise, is it's harder to palpate with those with higher BMIs. So the higher the BMI goes, the harder it is to be accurate in palpation. But again, my question is, what's the point of being accurate in palpation? For DOs, for surgeons, for MDs, this might make a large difference in certain procedures, especially anything where you're going to break the skin and implant or push implements into deeper structures. Ultrasound guidance is very important. So let's just say you're trying to do something like PRP to a knee. You should be ultrasound guided so that you can get to the target area better. That actually makes a difference. But manual therapists can't do that. It's legally not a thing. For things like, I don't know, like PRP is probably the easiest one. But anytime you're breaking skin to try to do some procedure, do something that's deeper, let's just say you're trying to drain a cyst. Like, depending on the level of that cyst or the depth of that cyst, you might actually need ultrasound guidance. So for that, yeah, it's important. But you're trying to find the cyst, not necessarily the bony landmark. So for the accurate identification of the thing that you're targeting, ultrasound makes a difference. But for most manual therapy practitioners, it's not going to make a difference because you're not breaking the skin. Say for acupuncture, it might actually be useful to avoid things that you don't want to disrupt. So it may be more valuable for acupuncture because you're going to break the skin. But for manual therapy, whether it's osteopathy, massage, chiro, physiotherapy, I don't know that this is going to make a difference. It'll make a difference for those who are allowed to use it to identify presence or absence of tear. Other than that, I don't think it would help manual therapy much. But again, for DOs, MDs, yeah, this is going to be helpful depending on the particular procedure or the particular diagnostic that you're running, because it's pretty quick and it would allow a relatively low-cost intervention or diagnostic instead of immediately going to things with higher radiological profile or higher doses of radiation. So it could be very useful to some in the DO context, yes, but for palpation, I don't think it's all that useful. Really, for manual therapy, regardless of form, you need to find out where the thing's not moving, get it moving better, and be accurate pre and post with how you've tested. The level doesn't seem to make much of a difference as far as I can tell. And I could be wrong, but part of it is just the tradition of people saying you have to be accurate to bony landmark, but no reason is provided other than you have to. So, yeah, I mean, the study, I think, was done reasonably well. It was targeting true novices with high likelihood of no prior training. So there's value when there's signal. I just don't know that it's applicable outside of that realm of those people who would have unlimited medical licenses and would be able to break skin for procedure and would utilize ultrasound for targeting that. But for palpation, I don't think it makes that much of a difference. Anyways, if you've listened this far, thank you very much. Hopefully you've learned something, and we will talk again soon.